Hi guys, I hope you guys are doing great. This is Dr. T and welcome yet to another episode. In this one we'll be talking about vaginal discharge syndrome. Vaginal discharge syndrome. Okay, as I said that this is a female version of male irritable syndrome, if I can put it that way. So also known as VDS. So this is a patient who presents with PV discharge plus minus other symptoms. So it's gonna be a female, right? It's gonna be that female patient that will present with PV discharge. Obviously, they might tell you about the volume, they might tell you about the color, tell you about its odor. They might also have itching. They might complain of itching. They might complain of burning on nutrition. They might also complain of what other things? Dyspareunia. Dyspareunia. They might also complain of other symptoms, guys. Other symptoms. But what we are more interested in is the discharge. So VDS is a more of an inclusive diagnosis. It caters for so many conditions under it. It's a safe assessment to make, especially when you're not sure. Like, you know, when you get someone who has one thing that we need to really make peace with, if I may put it that way, is not every patient who comes in with PV discharge, they've got a sexually transmitted infection or they've got a sexually transmitted disease. It's not like that. Yes, about 70% of patients that present with VDS, they've got STI, or probably even more. But then there are those that are not having an STI. And labeling everyone who's got a discharge as having STI can result in, first of all, ineffective management, ineffective treatment, and ineffective treatment, wrong diagnosis, and the patient will continue to have problems because the actual cause has not been treated. Like, for instance, okay, so someone who's got a PV discharge, as much as the approach, yes, is gonna be take the history and all of that, including yes, the other symptoms they might be having, because the more they talk, the more they will lead you to a diagnosis. The list is endless. So yes, you will cover the gynae history. You will cover the obstetric plus obstetric history. Yes, you will cover, most importantly, sexual history. On the past medical history, we need to know about other conditions like diabetes, especially if it's an elderly person, we want to know about the RVD. Why would we care about diabetes on a patient who presents with discharge? Why would we care about these are like systemic diseases, things like SLE. So it becomes very important. Sexual history, like we said yesterday, that when you've got male urethral syndrome, it's an opportunity to talk about HIV, counsel the patient on testing, knowing their status, use of condoms, and all those things. Yes, you will do your history, and yes, you will do your physical examination and all of that. But so this patient has got PV discharge, right? But this discharge, you don't know where it's coming from. You don't know the cause, because this discharge can be due to some kind of vaginitis, or it can be secondary to cervicitis, right? And cervicitis is caused, it's a typical kind of STI, kind of an inflammation. So the causes there include Neisseria, gonorrhea, chlamydia, trachomatis, mycoplasma genitalium, So, but when a patient comes in with PV discharge, there is no way you're gonna jump in and say it's cervicitis, it's STI, because they could be having vaginitis, they could be having bacterial vaginosis, which has got nothing to do with sexual intercourse. Bacterial vaginosis, right? Bacterial vaginosis is an overgrowth of, when you disturb your normal flora because of the things that people use to wash, hygiene products, things like that. So you can have an overgrowth of your normal flora and then they cause vaginosis. It's called bacterial vaginosis. Or you might be having candidiasis, vaginal candidiasis, or the patient might be having candidiasis. Hope it's right. Okay, so that's candida. Or they might be having a sexually now transmitted infection, trichomoniasis, which is caused by Trichomonas vaginalis. So if you look at these are your, if I can say, these are your infectious causes of a PV discharge, right? But we also have non-infectious causes. So this is your thinking as you take your history. This is your thinking as you take your history. Could I be dealing with an STI? And yes, you don't want to miss PID, pelvic inflammatory disease. You don't want to miss that, but your patient will present with other symptoms as well, obviously, which, as I mentioned, you have to look at. So a patient comes in with a PV discharge. As you take the history, you're thinking, could it be some kind of an STI? And you know the causes. Or could it be that they just have a localized vaginitis, and these are the most probable causes? Or are they having pubic discharge because of a non-infectious cause, which include things like vaginal atrophy, which is common in the postmenopausal women, vaginal atrophy, even foreign body, retained foreign body, which can be a tampon, which can be a condom, right? Or their non-infectious can be due to allergies, or these hygiene products that can be irritating to the vaginal mucosa. So hygiene products and things like diabetes, things like SLE, systemic diseases. Now, with diabetes, it's very common. Diabetes causes a lot of fungal infections are very common. So especially vaginal candidiasis is very common with diabetic patients. It's very common. So, but they will come in with a pubic discharge. It's gonna be that patient who's diabetic. They come in with a pubic discharge. But the difference, as you take the history, the pubic discharge is non-foul smelling. It's very, very itching, very, very, very itching. So, and the treatment is not an antibiotic. It's clotrimazole vaginal cream. That's what we use, or even a tablet. So I hope you can appreciate that not everyone who comes in with a pubic discharge has got STI. Otherwise, you will be frustrated when you give them these antibiotics for an STI, but they're not getting any better. So as you take your history, always think about these things. Don't underestimate diabetes causing vaginal candidiasis. It's very, very, very common. And also, that elderly lady who no longer has estrogen now, they get atrophy of the vagina. They will come in with a discharge and being they might even bleed. So because their vaginal walls are very thin and all of that. So, and then now you can start to entertain your STIs. So basically, as you take your history, if a patient says, I'm not sexually active, or I've not been with my sexual partner for the past 2 months, respect that. Don't be frustrated when you've got a PV discharge and then someone says, I'm not sexually active. Look at this. Look at this. This is the teaching today. This is the teaching today. So let's not, I know it's so frustrating when you take a history from a patient and then they look as if, or they seem to be denying your probable diagnosis as you are asking them, you've got the differentials, and then they keep denying your crucial information. So don't be frustrated when they say, I'm not sexually active. Go on and look at other things. So now, so as you approach them, as you take the history, you're thinking about this, right? Now, after doing your history, obviously you're gonna go and do a physical examination. When you do a physical examination, yes, abdominal examination is very important. Abdominal examination is very important because you might find that they've got suprapubic tenderness as well, or they've got some kind of mess in the pelvis or whatever. So do your abdominal examination. And also, when you do your GUT exam, genitourinary examination, make sure that you do the inspection properly. On your inspection, you want to check the panty liner, check the whatever that you can find there, how the panty is, how wet it is, the kind of discharge that you find, the color, all those things, how profuse is it, and look for any signs of irritation around the erythema, any rash, because systemic illnesses or some kind of irritants may cause some kind of localized dermatitis. Look at if you're gonna find warts, messes. That's just your inspection. And then also do try and examine the clitoris as well. And then that's your inspection. And then when it comes to digital examination, as you go in, you examine the walls of the vagina, look for messes, look for tenderness there, and then you go to your cervix. How smooth is it? Is there cervical excitation tenderness? Because if you've got that, then now you have PID, most probably. And then you check how smooth is it? Is it painful? Are there any messes there? Is it smooth? Is it regular? Is it irregular? And then as you come out, you look at your gloved finger. What the nature of the discharge? Is it foul smelling? Is there blood? And all of that. And by that time, you would have found your most probable diagnosis. Yes, about 70 or 80% of the times, this will be the culprit, especially if someone is young and productive years. So we're going to talk about the other tests that you can do on part 2 of this. But yeah, for now, let's leave it here.